welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Today, we first have Holly Green, who is a PGY2 EM pharmacy resident at Denver Health. And today she will be presenting a journal club on Reteplase versus Alteplase for acute ischemic stroke.
So for a little bit of background, so I'm sure we've all heard of Alteplase and Tenecteplase. And so this is another genetically modified form of Alteplase. So Reteplase does a similar thing. So it cleaves plasminogen to plasmin, which then initiates fibrin breakdown and causes fibrinolysis to break down a clot in the case of an ischemic stroke. And so a little bit of comparisons between the different agents. So I thought this was really interesting because these aren't new. So Alteplase first came out in 1989, and then we had Reteplase soon after in 1996, and then Tenecteplase came onto the market in 2000. And so I have the FDA approved indications here as well. So Reteplase and Tenecteplase are both approved only for STEMI, and then Alteplase has more indications with acute ischemic stroke, massive PE, as well as STEMI. And then you can see the dosing here. So Reteplase, the dosing that was used in this trial is 18 milligrams IV bolus. You give that over 2 minutes, and then they give a second 18 milligram bolus 30 minutes after the initial. And then Alteplase standard dosing here, it's 0.9 mg per kilo, max of 90 milligrams. You have 10% of it as a bolus, and then the rest over an infusion over an hour. And then Tenecteplase dosing 0.25 mg per kilo, max of 25 milligrams, just as a one-time bolus. And we can look at the cost here. So the cost for Reteplase is broken down in units online. So for 20 units, that would be about the amount that you would need in this situation. 18 plus 18 is $3,600, whereas Alteplase and Tenecteplase are a little bit more expensive, about $10,000, with Alteplase being the most expensive. And then lastly, looking at the fibrin specificity. So Reteplase is the least fibrin specific, Alteplase in the middle, and then you have Tenecteplase that's quite a bit fibrin specific than either of the others. Okay, so now looking at the prior literature. So like I said, these agents are quite old. So this is a study in 1997 that compared Reteplase with Alteplase, and this was for acute MI. And so in this study, they randomly assigned patients 2-to-1 to receive Reteplase, 10 units, about 18 milligrams versus Alteplase. It's open label, and they had about 15,000 patients in 807 different hospitals in 20 different countries. Getting at the primary outcomes, so mortality at 30 days, they were similar here with about 7.5% for Reteplase, and then Alteplase a little bit over 7%. And then looking at the other events, so stroke with Reteplase, they again were similar between the two. And then looking at their combined endpoint of death or non-fatal disabling stroke, again, similar between the two. Then looking at bleeding complications, severe life-threatening bleeding in Reteplase was 0.95% versus Alteplase 1.2%. So again, similar there. And so now fast forwarding up into 2024. So this is a study that was kind of looking at the ultimate dosing for Reteplase versus Alteplase. They assigned patients 1-to-1-to-1. So two different Reteplase groups. One was 12 plus 12 milligrams, and that's 61 patients. Then they looked at the 18 plus 18, which is 67 patients. And then Alteplase, 52 patients. And so it was open label, but a blinded endpoint. This was at 17 different centers in China within 4.5 hours of symptom onset. And they looked at patients, adult patients up to 80 years old. And so looking for their primary efficacy outcome, they looked at the proportion of patients with the NIH score no more than 1 or a decrease of at least 4 points from the baseline at 14 days. And so looking at the two separate groups, so the 12 plus 12, 75% on the Reteplase group versus 72.7, and then Alteplase 78. So this was not significant here. Then looking at safety of symptomatic intracranial hemorrhage within 36 hours, 5%, which I think is kind of interesting with the 12 plus 12, 1.5 with the 18 plus 18, and then Alteplase of 2. Again, not significant, but you can kind of see how the 18 plus 18 made its way to be a little bit better than the 12 plus 12. But overall, Reteplase was well tolerated and did have similar efficacy to Alteplase. So now moving on to our study that was done by the same authors. It was published in the New England Journal of Medicine in 2024. And so this was conducted at 62 different sites in China, phase 3 multi-center, prospective, open label, non-inferiority randomized controlled trial with blinded assessment. So looking at our study population, so for our inclusion criteria, included adult patients up to 80 years old, had to be less than 4.5 hours of symptom onset. They had to have an excellent functional status before onset of stroke. So we'll go over the modified Rankin scale, but they had to be a 0 or 1 on that scale. NIH score of 4 to 25, and they had to be eligible, obviously, for thrombolysis. And they excluded anyone who was going to undergo endovascular thrombectomy or who had one in the past. So looking at our methods, so this is one-to-one group assignment. So there were a little over 1,400 patients, 707 in Reteplase, and then 705 in Alteplase. And you see the dosing here, the 18 milligrams, and then an additional 18 milligrams given 30 minutes later. And then Alteplase, our standard stroke dosing here. So going on to our outcomes. So for their primary efficacy outcome, they're looking at excellent functional outcome, which was a score of 0 or 1 on the modified Rankin scale at 90 days. And so you can see here that represents no symptoms at all or non-significant disability. And we see as the scale continues going on to severe disability and then death out of 6. Then looking at our primary safety outcomes, so this was symptomatic intracranial hemorrhage within 36 hours after symptom onset, which is a common safety outcome that's reported in these studies. So then looking at our secondary efficacy outcomes, so they're looking at a good functional status, including 2, going up to slight disability on the modified Rankin scale at 90 days, and then looked at the distribution of the scoring at 90 days, recovery of their NIH score, which was defined as a decrease of at least 4 points, or less than or equal to 1 at 24 hours and at 7 days. So looking at the early functional return. And then looking at the Barthel index score of at least 95 at 90 days, which is kind of a scoring tool that looks at ADLs or their activities of daily living, including all these things here. And so a higher score represents less dependency. So a higher score would be better in this case, whereas 0 to 20 would be total dependency. So then moving on to our secondary safety outcomes. So they looked at symptomatic intracranial hemorrhage defined by ECAS-3 within 7 days, parenchymal hemorrhage within 36 hours, any intracranial hemorrhage, major hemorrhage, and then non-clinically relevant but non-massive hemorrhage, and then death from any cause, and any serious adverse events within 90 days. So then going on to our statistical analysis, they assumed, based on prior studies, that a modified Rankin scale of 0 or 1 would be achieved in 62.5% of patients in the Alteplase group. And so in order to provide 85% power for non-inferiority, they needed 1,412 patients, which is exactly what they were able to recruit. This was an intention to treat protocol, and then they used Poisson regression models to calculate risk ratios and logistic regression for the modified Rankin score analysis. So now going on to the baseline characteristics. So looking at median age was about 63 in both of the groups. About 30% of the patients were female. 100% of the patients were of Asian race, as this was conducted in China. Median weight was about 68 kilos. And then looking at their coexisting conditions. So about 75% also had hypertension, about 25% with diabetes, 40% with hyperlipidemia, 25% with the history of coronary heart disease, and then about 15% with an arrhythmia. Then going on to more baseline characteristics, so their NIH score at admission, so median was around 6. And then looking at patients that were from 4 to 7 was about 65% versus over 7, about 35%. And then modified Rankin scale before the stroke, so 0 was most of the patients, about 90%, and then 1 or 2 and between 6 and 10%. And then looking at the time from symptom onset to administration was about 3 hours in both of these groups. And then looking at less than 3 hours was about 50%, and then more, but the 3 to 4.5 hours was 52%, 53 in both groups. And then the median time of arrival to administration was about an hour in both groups. All right, looking at our results. So as far as our primary outcomes, so the modified Rankin scale of 0 or 1 at 90 days. So Reteplase did show a non-inferiority to Alteplase. So about 80% of the patients in the Reteplase group did have excellent functional outcome at 90 days. And so you can see a risk difference of 9.4 percentage points here, compared to Alteplase with 70.4%. And then looking at our secondary outcomes, including patients who had a modified Rankin scale of 2, goes up to 85% or 79% here with a risk difference of 5.8. And then looking at dramatic recovery, I thought that this was interesting here, that the patients in the Reteplase group had a higher percentage of patients who had early dramatic recovery at 24 hours and at 7 days. So 58% at 24 hours versus 48, and then 74% versus 67%. So you can see the risk difference here. And then continuing on with the secondary outcomes of their distribution of the modified Rankin scale. So you can see majority of the patients fall into the 0 to 1, but then we did have some patients that went on, with death being the worst outcome, obviously, 4.7 versus 3.8 in Alteplase. Then for the safety outcomes, I'll highlight a couple here. So these across one, so not a significant difference, but you can see that symptomatic intracranial hemorrhage within 36 hours and within 7 days was similar between Reteplase and Alteplase when you looked at just the patients who actually got the drug. And then death, again, was similar between the groups, between both at 7 days and at 90 days. But any intracerebral hemorrhage within 90 days was a little bit higher in the Reteplase group with the risk ratio at 1. But yeah, 7.7 versus 4.9%. And then looking at any adverse events that included a wide range of different things. But we did have a higher incidence in the Reteplase group with 91.6 versus 82.5. So as far as the discussion goes, Reteplase did have a higher percentage of patients with excellent functional outcome at 90 days in Alteplase, showing that it is non-inferior. And Reteplase did have a higher percentage of patients with early dramatic recovery at 24 hours and at 7 days. They did have a similar incidence of symptomatic intracranial hemorrhage and death. And then Reteplase had a higher incidence of any intracranial hemorrhage and adverse events at 90 days. So going on to the critiques, so the strengths I thought for the study was they did have a really large sample size. It was randomized, multi-center. They did use an intention to treat protocol. Definitely adds to the literature, as we haven't had much literature for acute ischemic stroke for this medication. They used patients with lower NIH scores, so potentially that could be where you would most want to use this drug in. But as far as the weaknesses, it was open label. There's no comparison with Tenecteplase, so I think that'd be really interesting to see in the future. So obviously we have some data for Alteplase, but need more Tenecteplase. And they did have some data missing for 3% of patients for the primary outcome. It was conducted in China, so less generalizability to our population in the United States. And then they excluded patients that were eligible for a thrombectomy, so something to keep in mind. And then also excluded patients older than 80, as we know that they'll be at higher risk of bleeding. And then the other thing I think is interesting with Reteplase is just kind of the administration difficulty. So I can picture in the emergency room, if you're starting somebody with a bolus and then have to wait 30 minutes for the next one with like transferring patients and just everything going on, I think that could definitely be kind of difficult with Reteplase as well. So as far as my conclusion, I thought that Reteplase was a reasonable and cheaper alternative to Alteplase in younger patients with lower NIH scores with debilitating symptoms of acute ischemic stroke if it's within the 4.5-hour window of symptom onset. And here are my references, and here's my contact information. So I can go ahead and take any questions now.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.